So, greetings from Galway, Ireland. My name is Dr. Phil Boyle, and I would like to present to you the experience I've gained from treating my subfertile patients with low-dose naltrexone. In particular, I want to share my experience of treating women during pregnancy with low-dose naltrexone. Looking at this. So what is the story? Why would you even want to use low-dose naltrexone during pregnancy? Well, for us, naltrexone is important when it comes to fertility. Our immediate goal through our clinic is to improve health, and we would observe that if women complain of fatigue, premenstrual syndrome, low mood, anxiety, or difficulty sleeping, that they would have increased difficulty achieving a successful pregnancy. And our clinical experience has shown that if we would address these symptoms through a combination of changing the diet, adding low-dose naltrexone, and giving various nutritional supplements, that we would improve those negative symptoms, improve the woman's health, and then get improved outcomes for couples we are treating with infertility. In 2006, we observed that clinically miscarriages and premature delivery were more likely when we stopped low-dose naltrexone during pregnancy. So the health gains that we had observed from low-dose naltrexone were lost during pregnancy when we stopped the medication, and we had less favorable outcomes. So because of that, we wanted to start using naltrexone during pregnancy. But like any medication, there's always a real concern using any treatment during pregnancy, and naltrexone is no exception. We don't have to look far back to consider the harrowing effects of thalidomide during pregnancy that was marketed as being perfectly safe and was given for the relief of morning sickness in the 1950s, in particular in Germany and the United Kingdom, and it resulted in devastating limb deformities. And many children suffered from these limb deformities, and obviously it affected them for the rest of their lives. And in addition to the issue with thalidomide, then there was diethylstilbestrol, which was more sinister in many ways because the effects weren't as obvious, and it was given for a total of 31 years between 1940 to 1971 before the problems were identified with it. It was given to pregnant women in an attempt to try and reduce the risk of miscarriage. It was even FDA approved and given to over 3 million women in the United States. In 1971, it was proven to cause clear cell carcinoma, a rare vaginal tumor in girls who had been exposed to it through pregnancy when their mothers had taken it. And 24 years after FDA approval, this shocking discovery was made. So we always have to be very careful taking that into account, that any medication during pregnancy, you have to be concerned about it. Not only were the babies affected later in life, with vaginal adenocarcinoma being 40 times more likely, the women who took it had an increased risk of breast cancer later in life. Their female children had increased risk of breast cancer, as well as abnormalities in the reproductive organs, increasing the risk of infertility and miscarriage. And the male children were affected as well, with reproductive abnormalities and increased risk of prostate cancer. And not only that, but it also went on to affect the third generation, and it is believed that changes that surround the genetic code, called epigenetic changes in the gene expression, would be passed on even to the next generation again. So it has this transgenerational negative effect, which is a real problem. So absolute caution and cognizance of potential risk in pregnancy is paramount when you give any medication to a woman who is pregnant, not just for her well-being, but that of her child as well. If we look at the naltrexone in pregnancy information from the medicines.ie website, which we reference in Ireland, animal studies don't show any teratogenic effect. And in at least this source of information, they say there is no experience using naltrexone in pregnancy. And of course, well, that isn't entirely true, because we do use it during pregnancy, and we're not the only ones. Others have used it before us as well. In particular, the website tells us, for the physician's reference, that this drug should only be used in pregnancy or during breastfeeding if considered essential by the physician. And this is a real good thing, because there are times when the evidence isn't there, but we can make a good informed decision that this is a reasonable thing to try. And clinically, Dr. Hilgers in Omaha, Nebraska, the United States, who developed the treatment protocols that we use for infertility, he has been using very high doses of naltrexone safely in pregnancy for years. Also, there are publications for giving high-dose naltrexone treatment for opioid-dependent women, and these publications appear periodically, and they show that there are no birth defects or obvious problems for mums or babies. So that's a positive and an encouraging thing, and there is that degree of experience. But this is high-dose naltrexone, which is a very different clinical effect to low-dose naltrexone. Remember, high-dose naltrexone blocks opioid activity, and the treatment we give actually promotes opioid activity to get optimum activity, and clinically there are many additional benefits that we would expect to see from low-dose naltrexone that you don't get with high-dose naltrexone. So naltrexone in pregnancy, we observed more benefit with naltrexone in pregnancy for women with autoimmune conditions, women with repeated miscarriages, those with endometriosis, polycystic ovaries, and clinical endorphin deficiency. So presently, I give this treatment to women in these categories in my practice. Currently, up to 50% of my practice population takes low-dose naltrexone, often right throughout pregnancy. There's little or nothing in the published literature to support our practice or to encourage other doctors to do the same. And the questions that we wanted to address with our recent patient survey was, is it safe to take naltrexone, low-dose naltrexone during pregnancy? Are there additional benefits to either mum or baby from taking low-dose naltrexone? Because clinically we would observe benefits, so we wanted to see if we could capture that through our questionnaire. And the third question we wanted to answer through our patient survey was, how long should you take naltrexone for during your pregnancy? We designed our survey, and the link to it is there. It's through SurveyMonkey, and LDN in pregnancy would help you to find that. There were 39 questions in total. It was anonymous, so we couldn't identify patients. We thought we might improve the response rate that way. And our focus was on safety of the treatment and getting couples, or women in particular, to let us know their experience, whether it was positive or negative. Unfortunately, a deficiency in our study design, automatically we have all this information in our system, and an oversight on our part was when we made it anonymous, we couldn't identify female age and aspects of their history that would be important, including duration of infertility, previous pregnancy history, previous fertility treatment. So it means that we have to exercise a degree of caution when interpreting our data, because we're unable to correct for these variables that are obviously very important when it comes to fertility. But despite that as a limitation, this is still a useful survey. And with our survey, we collected data from 237 successful pregnancies, and about half of them used naltrexone during pregnancy, and the other half didn't. So we had a very good comparison group and a reasonable number, and our overall response rate was nearly 80% of those who opened their emails. This was an emailed survey drawn from patients' records, or from the entire list, including those who didn't get to open their email. It was an overall 67% response rate. So it was a very good response rate, which helps to say that it's a representative sample of people we had treated. And interestingly, I would have clinically judged it was 50-50, and it's pretty close to that when we looked at our data for the number that we feel take naltrexone during pregnancy. So there's our numbers of the 237 total and roughly a 50-50 divide. And our question was, at how many weeks was your baby born? Well, for those who took naltrexone, we had a 6% premature delivery rate, and that was broadly similar in the other group that did not take naltrexone during pregnancy. It was a 7%, so that's comparable, and we'd say no real difference in prematurity between those two groups. And the next question, we said, what was your baby's birth weight? And we found that 3% were born 5 pounds or under, and that applied to both groups. So again, no real difference between those groups. The next question was your baby in the special care baby unit? And 13% of the babies whose mothers took naltrexone during pregnancy were in the special care baby unit, compared to 18% in the other group. Complications during pregnancy was roughly the same between the two groups, 17% compared to 20% in the non-naltrexone group. The next question, did your baby have any complications during delivery or after delivery? 12% in the naltrexone group, 14% in the non-naltrexone group. So we would regard those as comparable and little or no difference between them. Then the problems that we did identify were congenital anomalies, and there were 3 babies born with congenital anomalies in the naltrexone treated group, compared to just 2 in the non-naltrexone group. The one anomaly that was quite unusual was this congenital cystic adenomatoid malformation of the lung, and this is a rare condition, and there's no evidence to suggest that it's caused by anything that you've done during pregnancy. It affects about 1 in 10,000 babies, and thankfully it's not a serious issue for most, and in the case of the baby who had it in our group, it was a non-serious issue. In the group that weren't exposed to naltrexone, there were 2 congenital anomalies. One was an underactive thyroid, and the other baby had seizures from 3 days old, needing medications to control, and this was the non-naltrexone. And these things can happen randomly, and no good reason found to explain that. So on the next slide, I'll race through these pretty quickly, and we ask questions, is your child healthy? And it was 100% yes for both groups. The next question was, would you say your child is a good sleeper? No real difference between the two groups. Is your child a good eater? No real difference between the two groups. And is your child contented or fussy? And again, no difference at all between the groups. And then the next question was, what about, did your child need an antibiotic for a chest infection? 37% of babies needed the antibiotics in the early stages of life in the naltrexone group, compared to 34% in the non-naltrexone group, and really no real difference between the two. What about allergies? 10% in the naltrexone group, and same number in the non-naltrexone group. Overall, has your child reached the developmental milestones? 3.5% late in the naltrexone group, 2.5% late in the non-naltrexone group. And there was no real difference between the incidence of breastfeeding to separate the groups, 68% in the naltrexone group, 71% in the non-naltrexone group. So then we get to the point that's a little bit more interesting regarding the naltrexone use itself. So what was naltrexone like for those 120 women who did use it before conception? And did you notice any side effects beyond the first 2 weeks? Well, 12% said that they did notice side effects. And the side effects included our typical side effects, vivid dreams, sleep disturbance, and a few other minor side effects. And how severe were those side effects? Well, about 7.5% said they were moderate, and a few said it was even less than that. So they weren't very serious side effects. And did you notice any benefits to treatment with naltrexone? 65% of those who took it noticed significant benefit from the naltrexone. And the kind of benefits they observed were profound: improved mood, more energy, improved sleep, improved premenstrual syndrome, reduced period pain, reduced joint pain, reduced muscle pain, improved bleeding, and other benefits as well. So it was definitely clinically very beneficial for the people who took it. And the degree of benefit was nearly 90% said it was moderate, significant, or very significant, with only about 11% saying it was mild or minimal improvement. So these were big improvements in multiple areas, and we'd observe this clinically, and we would observe when we'd stop that our pregnancies didn't go so well. So we wanted to really have a look at what's going on here during pregnancy. And so when we broke it down, people stopped naltrexone at various stages in the pregnancy. And the one we are really interested in is those who took it 26 weeks and beyond, and we compared that group with those who took it for up to 25 weeks. So they're the two groups that we wanted to draw the comparison with. How did they do? Well, those who stopped it before 25 weeks, 73% of them noticed a benefit to treatment with low-dose naltrexone. And those who took it beyond 26 weeks, a similar percentage noticed benefit from the naltrexone. When we looked at their birth weights, we found 16% had early delivery if they stopped the naltrexone prior to 25 weeks, compared to no early deliveries in the group who took naltrexone beyond 26 weeks. And straight away, that seems to be a significant difference. So if you look at the two slides compared together, they appear to be significant, but when we apply statistical calculations, it does not achieve statistical significance, which is quite annoying, but I'd say it's just because our sample size is small. Moving on to the next slide, what about your baby's birth weight? Well, for those who stopped the naltrexone early, and bear in mind, these are people we felt needed the naltrexone and they stopped it early, and this is why we can observe that things didn't go as well as they could have done. Well, we found 13% were 6 pounds or under in weight, compared to 7% being 6 pounds or under in weight. And again, you compare the two slides together, and there appears to be a difference, 13% compared to 7%, but it fails to achieve statistical significance. So the trend is interesting, but we don't have statistically significant results at this stage. What about, was your baby in the special care baby unit? Well, those who stopped the naltrexone early at 25 weeks, 20% of the babies ended in the special care baby unit, compared to just 6% for those who continued naltrexone 26 weeks and beyond. And if we again compare these two, annoyingly, it doesn't achieve statistical significance. The other question, how long was your baby in the special care baby unit? So for those that stopped the naltrexone early, they seem to be in the special care baby unit for longer compared to those who took the naltrexone beyond the 26 weeks. Did mum have any complications after delivery? 27% said yes if they stopped the naltrexone prior to 27 weeks, and if they continued the naltrexone for longer, only 13% of women said they had complications themselves after delivery. What about your baby? 17% of babies had complications if naltrexone was stopped before 25 weeks. And if the naltrexone was continued for longer, it was only 2%. You put these two slides together and you'd say, surely that's got statistical significance, but when we apply our statistical criteria, it fails to achieve a significant p-value. So the trend is there. It's something we observe clinically, but we need to get larger numbers before we could prove this is a real effect. Another one that I find really interesting is, has your child needed antibiotics for a chest infection? 47% in those stopping naltrexone early, compared to 25% for those who took naltrexone beyond the 26 weeks. Again, it looks like it's significant, but the p-values don't add up, and we have to get bigger numbers before we can prove this. Another interesting one, developmental milestones, 11% reported that there was some developmental delay in those who stopped the naltrexone early, compared to none reporting developmental delay for those who took the naltrexone for longer. So certainly very interesting, but again, not statistical significance. So I think we could say there seems to be a trend, and it supports our clinical practice and our clinical experience that it may be beneficial, but yet to be proven scientifically. Interestingly, when we looked at the question of breastfeeding, there was a greater protective effect of breastfeeding in those stopping naltrexone early, with 77% of those breastfeeding in the sub 25 group, compared to just 60% in the group that took naltrexone for longer. So if anything, the breastfeeding factor was more in favor of the group that seemed to do less well. So back to these questions, is it safe to take naltrexone during pregnancy? I would say yes. It seems comparable between the two groups as to whether naltrexone is taken or not. The incidence of congenital anomalies is comparable, and there seems to be no difference when we compare roughly 120 users and non-users in each group. Are there additional benefits to mum or baby from taking low-dose naltrexone in pregnancy? I'd say, well, yes, probably for mum and baby, but yet to be proven scientifically. And in answer to the question, how long should you take naltrexone during pregnancy? From my clinical experience, I would encourage people to take it right throughout pregnancy. I usually stop it at 37 weeks in case mum needs some opioids during delivery, and it's just because of the potential for interaction with opioids that I would stop it, but not for any other reason. So for those of you with autoimmune conditions or any other reason as to why you may need to take naltrexone, I would say, based on our current information, it's a very reasonable thing to do. It's been around since 1985. It's been used at really high doses during pregnancy, and our clinical experience would go a little bit beyond to say that not only does it appear to be safe, but in fact there may be further additional benefits to taking naltrexone for both mum and baby, and it should be taken right throughout the pregnancy. But if I can dream, we have the potential to do an awful lot more. I believe we have the possibility to improve the health of future generations. There is a new concept we're looking at regarding the epigenesis on endometriosis, and the epigenetics are their chemical tags that are found on our genes, and they influence gene expression, and they have a role to play in the expression of endometriosis in the next generation. My hope is, based on information from Dr. Alejandro Leal, an internationally renowned geneticist from Costa Rica, that if we continue naltrexone during pregnancy, our hope is that it will have a positive beneficial effect on the epigenetic component of endometriosis. When there is excessive stress in the environment, the baby's genome is affected, so this is where the unborn child is saying, my genome is being methylated secondary to stress. Well, we know there's a lot less stress and distress and a lot less negative symptoms like that during pregnancy, and because of the multiple beneficial effects that naltrexone gives to the physiology, our hope is that it'll have a positive epigenetic impact on the females of women with endometriosis, reducing the expression of endometriosis in the next generation. This study from the Journal of Molecular Psychiatry in August 2013, looking at 2,700 mothers of children with autism, found that 1 in 10 of the mothers had anti-brain antibodies, which was a significantly higher incidence than in the normal population for women who had children without autism. Our strategy of dietary intervention, low-dose naltrexone and supplements is our immune-modifying strategy that clinically we suspect would reduce these auto-antibodies and potentially may be able to reduce the risk of autism in the next generation. And that's massively exciting. And finally, I want to close with a photo of friends and patients of mine who recently had a beautiful pregnancy, helped with naltrexone and our immune modifying strategy and all the things we do. And incredibly, she had 3 pregnancy losses when she was 44 to 45 and just delivered a healthy baby girl when mum was age 48 just a few weeks ago. So it's a little bit, I've seen 2 pregnancies in women of that age in nearly 20 years of clinical experience, but our goal is this girl is a beautiful healthy baby, and she's had been exposed to naltrexone during pregnancy, and she's perfectly healthy. And this is what I see: they're usually bright, they reach the developmental milestones, they don't seem to have as many chest infections, and I think we're doing something really good here. So I'll give an encouragement that although we have to qualify it and say we can't yet say we have all the scientific evidence we need, but it seems like a reasonable thing to do to continue naltrexone right throughout your pregnancy. Thank you very much.